Welcome to the BC Technical Webinar Series. Today's topic is New Technology Leads the Way to Lower Dose Myocardial Perfusion Imaging. This webinar session is worth one voice credit. In order to receive this credit, you must complete the online test, which will be available immediately after this webinar. A passing score of 80% is required for the voice credit to be awarded, and you may take the test more than once if need be. A certificate will be emailed to you at the close of this webinar and following successful completion of the online test. Please keep this certificate as proof of your completion of this webinar. Myocardial perfusion imaging, or MPI, has many important clinical uses and can provide significant benefits. However, myocardial perfusion imaging procedures present risks associated with radiation exposure. A balanced patient health approach seeks to support the benefits of medical imaging while reducing these risks. The FDA, Food and Drug Administration, along with ASNC, the American Society of Nuclear Cardiology, are working together to set forth guidelines for low-dose myocardial perfusion imaging. The volume of cardiac diagnostic procedures involving the use of ionizing radiation has increased rapidly within the last few years. In 1990, fewer than 3 million nuclear cardiology studies were performed in the United States. But by 2002, this figure more than tripled to 9.9 million. Even in 2014, this number tripled again. Myocardial perfusion imaging plays a central role in clinical cardiology and has contributed to the decrease in morbidity and mortality from coronary heart disease. Nonetheless, performance of any diagnostic test requires a careful assessment of the risks and benefits of the test and optimization of protocols to minimize risks to patients, staff members, and the public. Medical imaging has many important clinical uses and can provide significant benefits. However, the typical amount of radiation a patient absorbs through a myocardial perfusion imaging exam is relatively high when compared to other non-invasive radiography exams. Nuclear medicine as a community is working to change that. A balanced public health approach seeks to support the benefits of medical imaging while reducing the risks. The FDA, others in the federal government, and the healthcare professional community all have a role to play in such an approach. Through the initiative to reduce unnecessary radiation exposure from medical imaging, the FDA and our partners will work to measurably reduce unnecessary exposure of patients to radiation in nuclear medicine imaging exams. Here we have a slide of effective doses in all radiography imaging dealing in the cardiac field. So let's take a look at some of these. At the bottom on the left-hand side, we see a catheterization which has an average effective dose around 7 millisieverts. The next catheterization we have is a spiral CT, and that comes to about 19 millisieverts of radiation exposure. Next, we have a spiral CT with a tube current modulation, which is a lowering dose edition, and that comes to be about 13 millisieverts. If we go back to our basic chest CT and axial tube, we are looking at 4 millisieverts, and also a calcium score that has a specialized test in CT, and that comes up to 2 millisieverts. Looking into SPECT, we see normal technetium rest stress, and that is 10 millisieverts. Now, if we look at the dual isotope, which was the standard about 10 to 15 years ago, it has thallium stress technetium rest, and that ends up being 24 millisieverts. When we look at some of the newer imaging techniques, where maybe we do just a stress test only and we give a low dose of technetium, that turns out to only be about 4 millisieverts. Finally, we see PET with rubidium rest stress coming in at 3 millisieverts, and then one of the newer PET studies, which is the oxygen rest stress, and that comes in at 2 millisieverts. In 2014, the ASNC guidelines stated that 50% of patients undergoing myocardial perfusion imaging should have a radiation dose of less than 9 millisieverts. This was reported by .med.com, and these guidelines were established by the American Society of Nuclear Cardiology. This is lower than the 11 millisieverts associated with the most commonly used myocardial perfusion SPECT protocol, where it's a one-day rest, stress, low dose, high dose study. There are other protocols in nuclear cardiology that give higher doses than 11 millisieverts, but ASNC guidelines are trying to eliminate or at least minimize these other protocols that afford a higher radiation dose. Now let's take a look at radiation doses in just nuclear medicine. This chart shows the standard myocardial perfusion imaging doses. The top row is the most common, with a one-day rest stress technetium-99 based study, where we use 10 millicuries for the rest and 30 millicuries for the stress. Depending on if you are using MyoView or Sestamibi, you're going to get an average of 10 millisieverts, which is one below the recommended reduction dose. So right there, we are on the borderline. On the second line is a one-day stress test, where the stress has 10 millicuries and the rest has 30 millicuries. The result is about the same average, around 10 millisieverts. But what about the two-day stress tests, where both days you give a dose of about 25 millicuries? It looks like it goes a little above the Affordable Act, which wants 11 millisieverts, and yet we are averaging around 13 millisieverts. Now what about a stress-only test, where the patient is given 25 millicuries of a stress dose and we don't need the rest? It ends up being cut in half at an average of about 6 millisieverts, which is good considering that they want us under 11 millisieverts. If we go back to the old protocol, or not so old but maybe not as popular, where we do the thallium rest and high-dose stress, we're looking at 22 millisieverts. That is about twice as high as what they want us to achieve. Also, if we have to re-inject or do a redistribution with thallium the next day, that thallium gives up 15 millisieverts. The last stress test is the 3-thallium. We have the high stress and the re-injection and redistribution thallium, which shows a result around 20 millisieverts. When we talk about patient-centered health, we should ask ourselves, will the patient benefit from the myocardial perfusion imaging exam? That leads us to patient selection, which is the first and most important step of managing radiation exposure from MPI. When MPI is clinically appropriate, the benefits of accurate diagnosis and management are greater than the potential risk of radiation exposure. Once myocardial perfusion imaging is deemed appropriate, choosing the best diagnostic testing strategy requires evaluating the patient's symptoms and characteristics. Age, sex, and medical history should be considered in this situation. Unfortunately, the situation in nuclear imaging has not been as encouraging as in X-ray imaging. The main recommendation has been adjusting the administered activity based on patient's weight. This recommendation has not been followed rigorously. The radiation doses in many nuclear imaging examinations in the past were not as high as in CT, and the frequency of examinations were also not as high. In recent years, a few nuclear imaging procedures impart higher radiation doses to patients, like myocardial perfusion imaging. There are hybrid imaging modalities like PET-CT and SPECT-CT, The frequency of these examinations have been increasing, and there are special concerns on radiation dose reduction to children. The focus on radiation dose management in nuclear imaging thus requires more attention. Unlike X-ray imaging, where technology has contributed to what it can provide when an individual patient is in the machine gantry, the main contribution of technology in nuclear imaging has been developed for more sensitive imaging systems and the application of advanced imaging processing tools, like accelerated ordered subsets implementation, also known as iterative reconstruction. There is a need for better contribution of technology in individual patient dose management. With such a situation, the dose management tools remain the administration of at least radioactivity and adapt imaging protocols, both of which require attention for increased implementation. So the 2014 ASNC guidelines that are intended to reduce dose from nuclear cardiology procedures have offered up several different ways that the general public can do this. One of the methods that there has been a lot of discussion about is going to a stress-only protocol. Typically, there are two tests that are a part of the MPI study: a resting scan and a stress scan. The stress scan is either done through exercise or pharmacological stresses. So with the push to a stress-only imaging protocol, one of the methods that will make this successful is performing a highly selective patient selection. At this point, the patient who is likely to be low or low intermediate risk is going to benefit from the stress-only protocol, which will cut their radiation exposure in half, which is well under the new guidelines of 9 millisieverts that ASNC is reinforcing. So with patient selection and having an experienced physician reading the study, the stress-only protocol will definitely benefit the low to intermediate low-risk patients. Most recently, the media, the public, and the medical community have drawn attention to the patient radiation exposure associated with radiographic nuclear medicine and nuclear cardiology procedures, and the potential associated patient risk. The nuclear imaging communities have responded rapidly and definitively by implementing a variety of guidelines to decrease patient radiation exposure and to avoid exposure in higher risk patient populations. ASNC has set a goal to decrease patient radiation exposure associated with myocardial perfusion SPECT to less than 9 millisieverts per entire study in 50% of patients by 2014. The new software and hardware methods described will help us achieve this goal by providing the ability to maintain or improve SPECT image quality and lower image counting statistics associated with significantly decreased radiopharmaceutical dose. There have been several comprehensive reviews and editorials published highlighting innovations in the CardiArc SPECT software and hardware field. We hope the present review will serve to reinforce the importance and clinical significance of these technical advancements. Several manufacturers have begun to break away from the conventional SPECT imaging approach to create innovative designs of dedicated cardiac cameras. What these cameras' designs have in common are that all of their available detectors are constrained to imaging, like the cardiac field of view. These new designs vary in the number and type of scanning or stationary detectors, and whether sodium iodide or cadmium zinc telluride solid-state detectors are used. They all have in common the potential for a 5 to 10-fold increase in count sensitivity at no loss or even a gain in resolution. This results in the potential for acquiring a stress myocardial perfusion scan in 2 minutes or less if the injected dose is within standard. Some of this gain in sensitivity can be traded for a linear reduction in the injected dose to reduce the patient's exposure to radiation. Thus, in an ultra-fast camera with a tenfold increase in sensitivity using conventional radiopharmaceutical doses, the dose could be reduced by half and still maintain a five-fold increase in sensitivity. Let's first take a look at the DSPECT camera manufactured by Spectrum Dynamics. According to Spectrum Dynamics, the DSPECT manufacturer's primary goal was to reduce patient radiation exposure with its next-generation solid-state digital detector technology. The camera has the capability to count 10 times the speed of a conventional gamma camera, so it would reduce imaging time and reduce the total injected dose considerably as well. Also important to note is Spectrum's approach to ultra-low dose imaging. Their ability to start with a count-rich dataset prior to reconstruction is due to the DSPECT's 9 high sensitivity detectors focused on the myocardium, thus improving the target to background ratio. Coupled with the proprietary acquisition software, it automatically calculates the optimal time required to ensure consistent image quality with ultra-low dose imaging. Other approaches that work with conventional gamma cameras start with lower count densities before applying the software enhancements. Their reconstruction packages use resolution recovery for improved image quality as well. GE Healthcare has also released their own version of the dedicated cardiac ultrafast system that also has the potential to change the way nuclear medicine MPI is performed. It's called the Discovery NM530C. The camera can be used in a variety of ways according to the manufacturer. You can receive lower patient doses, faster acquisition times, increased resolution, and improved throughput. The camera uses CZT, which is cadmium zinc telluride. CZT replaces the standard sodium iodide crystals in gamma cameras that boasts better counting and higher resolution images. How will this affect a reduction in patient exposure? Instead of using standard doses in MPI imaging that account for over 10 millisieverts of radiation exposure to the patient, they will be able to cut the dose in half to bring down the overall patient exposure to 5 millisieverts. This ability is in line with the Reduction of Patient Exposure Act that the ASNC released in 2014, which tries to lower patient exposure under 9 millisieverts for MPI testing. Several other great factors about this camera are that it can focus collimation using pinhole collimators. It can hold stationary data acquisition, which means the camera is stationary with no motion. And lastly, what makes the Discovery great is that it uses new 3D reconstruction, iterative reconstructive formulas. The next SPECT system to offer a totally new design was the CardiArc, manufactured by a company of the same name. This system uses 3 detectors, similar to a conventional scintillation camera, but the detectors are curved and side by side to cover a 180-degree angle. Each detector consists of a curved sodium iodide crystal covered by an array of photomultiplier tubes. Horizontal collimation is designed by using a series of thin lead sheets that are stacked vertically, with the gaps between defining the hole apertures. Vertical collimation is achieved using a curved lead sheet with 6 vertical slits that fan back and forth during acquisition in order to obtain 180 degrees worth of data from the multiple projections. The motions of these 6 slits is synchronized electronically with the 6 areas of the crystal that are imaging the photons passing through the slits. What does all this mean in radiation exposure? Well, reducing radiation exposure can be achieved in several different ways when using the CardiArc's high-speed imaging system. It can perform rapid scans. It can perform standard length scans using a much less dose. And you could get the same benefits of shorter scans and a lower dose without affecting quality. Siemens Smart Zoom is the only technology today that performs the ultra-fast cardiac imaging with a general-purpose camera, the Symbia. Its unique collimator design, cardiocentric image acquisition, and advanced reconstruction technology acquires 4 times more counts than the conventional methods for high-quality images dependent of age, body shape, or size. With IQ-SPECT, physicians can perform a myocardial perfusion imaging study in approximately 4 minutes using the standard dose, 8 minutes using half the standard dose, or 16 minutes using 1/4 of the standard dose. With its smart zoom collimators, modified cardiocentric acquisition, and special reconstruction methods, IQ-SPECT is the solution for fast cardiac imaging using half the dose with twice the speed. Siemens Smart Zoom collimators employ the magnifying properties of a cone beam collimator near the center of the field of view and eliminating truncation at the edges of the field of view, similar to a parallel hole collimator. The unique position and shape of each hole in the collimator, also referred to as a vector map, is measured in the factory at Siemens and stored with the collimator to be used during reconstruction. The result is an increase of up to 4 times more sensitivity. Digirad's ultra-low-dose CardiArc 3 XP0 is their newest camera with solid-state detectors, which equals high count rate performance and offers the reserved capacity to meet the potential demands of higher speed imaging and lower dose scans. Digirad's Sodium HD SD, which is high-definition solid-state detectors, offers a number of distinct performance enhancements over conventional gamma cameras. It also has demonstrated outstanding image quality, consistency, and reliability. Solid-state detectors are more compact, more rugged, and conform better to the typical cardiac patient's body geometry. The XPO series cameras introduce new sodium, high-definition, solid-state detectors that raise the standard in image quality, reliability, and performance to a new level for the industry and practice of nuclear cardiology. The XPO series pushes the envelope one step further with the introduction of another Digirad exclusive. True acquisition count-based imaging, the first and only count-based SPECT imaging techniques that ensures consistent counts for every patient study, regardless of patient size, weight, or dose. This will allow the technologist to cut the standard dose in half and not have any change in imaging resolution, sensitivity, or quality of the scan. Since we have talked about reducing patient exposure with new hardware in nuclear medicine, aka cameras and collimators, now let's touch on some new software that's going to help reduce patient exposure in nuclear medicine as well. New SPECT scanner devices are coupled with improved image reconstruction techniques implemented in software. Most systems now offer compensation for image resolution loss, especially needed for the ultra and the high sensitive collimators through accelerated iterative reconstruction. With its sophisticated software, reconstruction methods can also improve image quality obtained by standard SPECT cameras. This can be exploited to reduce imaging time or radiation dose to the patient. The principal advantage of retrofitting the traditional systems with the new software is done at a significantly lower cost compared to replacing your nuclear medicine camera with a new ultra-fast system. Filtered back projection, FBP, has been the standard method for reconstructing SPECT MPI. Filtered back projection has problems with low-count SPECT images due to the inevitable artifacts of image noise. And this mandates higher radiation doses or longer acquisition times for forward back projection to be a useful filter. Also, filter back projection is unable to correct for attenuation artifacts and scatter problems as well. Iterative reconstruction refers to a broad category of SPECT and also PET reconstruction techniques that estimate the distribution of the radioactivity being imaged by mathematical algorithms. The generated projections are compared to the actual acquired projections, and the difference is used to improve or estimate the estimated distribution. If the algorithm is designed correctly, the estimate approaches the actual distribution being imaged, and the difference is minimized, which means less noise. Using iterative reconstruction allows the injection of a lower radiation dose and correction for the nature of the noise as well, with obtaining minimal attenuation and scatter correction. Siemens Medical Solutions has developed a new iterative reconstruction filter called Flash 3D. It's commercially available, and Siemens calls it as an OSEM filter, used for reconstruction with 3D collimator beam modeling and optional attenuation correction with clinically acceptable reconstruction times. OSEM, which is the same method as iterative reconstruction, stands for Ordered Subset Expectation Maximization. The results so far show that OSEM 3D improves image quality both visually and semi-quantitatively. It also shows that 2-beam modeling may result in similar contrast to 3D if the geometry of the distribution is axially invariant. However, even in such a case, subtle changes, such as lower noise and better contrast due to 3D beam modeling, exist because the volume is reconstructed in its entirety versus the OSEM 2D reconstruction. In OSEM 2D reconstruction, each slice is independent of its neighboring slice, which is physically not true. OSEM 2D essentially assumes primary photons impinging within the collimator acceptance from neighboring slices as noise. So OSEM 2D can increase noise and decrease resolution, versus the new Siemens Flash OSEM 3D and also OSEM 3D, which allows for lower doses and keeps the same amount of time during scans to decrease patient radiation exposure. Philips has come out with their own advanced reconstruction algorithm. It's called Astonish. It is located within the AutoSPECT Plus application, and it provides patient-specific and collimator-specific corrections with resolution recovery. It utilizes the Philips patent matched dual filtering technique to minimize noise and improve uniformity. Reconstructive resolution has been shown in a NEMA SPECT Phantom to improve from 10 to 11 millimeters to more like PET-like levels of 4 to 5 millimeters. Image contrast and signal-to-noise ratio are also enhanced with Astonish reconstruction. Since its initial introduction in May 2005, Astonish method has been adopted by approximately 800 clinics worldwide, and several clinical trials have been conducted. Because Astonish provides improvement in signal-to-noise ratio, it can provide equivalent image quality even when SPECT scan times are shortened. By reducing patient imaging time, a higher throughput can be achieved. A shorter scan time may also mean more comfort for the patient and fewer motion-induced artifacts. Philips has collaborated with strategic partners on clinical research studies that evaluate half-time acquisitions for data reconstruction with Astonish. This data is being evaluated by certifying bodies for updating cardiology guidelines to reduce patient doses in nuclear cardiology. GE Medical has released Evolution for CardiArc, which is an innovative SPECT reconstruction package for both gated and non-gated technetium-99m-based nuclear medicine myocardial perfusion SPECT imaging, which improves image quality while reducing imaging time up to 50%. Myocardial perfusion imaging is one of the most frequently performed procedures in cardiology today, providing important information about the heart and the coronary arteries that feed it. These studies require a significant amount of imaging time, often in excess of 15 to 20 minutes each, for the rest and stress SPECT imaging session. Additional time is required for attenuation correction, which can significantly reduce attenuation artifacts associated with breast, muscle, and diaphragm tissues. Evolution for CardiArc can also enable reduced injected dose by up to 50% while preserving scan time and image quality. It allows clinicians to generate quality exams with or without CT-based attenuation correction in less time or with less dose, and without compromising productivity and workflow. Image quality is clinically equivalent to that of the forward back production or the BP-OSEM full-time acquisition. WBR UltraSpec's exclusive reconstruction algorithm technology resolves a sensitivity and resolution trade-off problem that is inherent to the gamma camera and which is critical in SPECT imaging. In SPECT, the patient data acquired in a series of two-dimensional images, or projections, are back projected into the reconstruction process into a virtual 3D space, yielding an image or a series of images very similar to the real 3D distribution of the radioisotope within the body. Unlike current SPECT reconstruction technologies, wide beam reconstruction does not assume the photon rays detected by the detector crystal to be perpendicular to it. Rather, it employs an intelligent and accurate iterative image reconstruction process that enables simultaneous resolution and contrast recovery, coupled with noise suppression based on an accurate physical modeling of the photon emission and detection. Additionally, wide beam reconstruction can be utilized to lower the radiopharmaceutical dose administered to the patient, maintaining the same image quality and acquisition parameters. Same application, same camera, same collimator, same patient, and same scan time, but lower radiation exposure. CZT solid-state detectors provide improved energy resolution as compared to sodium iodide detectors. With improved discrimination of the photopeaks of technetium-99m and thallium-201, there is considerable future potential for simultaneous imaging of the radiopharmaceuticals labeled with these two isotopes. Thallium-201 emissions are better discriminated from technetium-99m photon using CZT detectors. Using the DSPECT camera, a test was implemented in a 20-minute sequential stress thallium-201/resting technetium-99m protocol, demonstrating similar image quality to that obtained using a standard rest-stress technetium-99m protocol. The advantage of using thallium-201 for stress imaging is its higher myocardial extraction, potentially allowing improved detection of stress-induced myocardial perfusion defects performed simultaneously. Patients were given 2.0 millicuries resting thallium-201 and 6.8 millicuries stress technetium-99m dual isotope SPECT while using the DSPECT camera in 27 consecutive patients. It was reported that image quality, diagnostic results, and the summed stress score and summed rest score were very close to the separate myocardial perfusion imaging scans. This method will cut the patient radiation exposure by 2/3 versus a normal dual isotope study. New software and hardware methods described in this webinar have been demonstrated to decrease SPECT acquisition time, injected radioactivity, or both. The potential advantages of shortening image acquisition time are considerable. Patient tolerance is improved, the opportunity for patient motion is decreased, and laboratory throughput is improved. Decreasing radiopharmaceutical doses while maintaining a longer acquisition time in order to decrease patient radiation exposure effectively addresses concerns of the public and the media and the latest recommendations by the American Society of Nuclear Cardiology. Combining these two potential advantages, there is the opportunity to customize scan protocols in order to meet specific patient requirements. For example, in a younger patient in whom radiation exposure is a concern, a reduced radiopharmaceutical dose and a relatively longer acquisition may be preferable. In an obese patient, in order to increase image counting statistics, as an alternative to weight-based radiopharmaceutical doses, a standard or reduced dose could be given in combination with a full-time or even prolonged SPECT acquisition with an image acquisition time customized to provide adequate counting statistics. Although reduced image acquisition time and/or decreased radiopharmaceutical doses are obvious potential clinical advantages of the software and hardware methods described, these methods also may potentially hold promise in improving the diagnostic capabilities of myocardial perfusion SPECT due to their ability to cope with lower image counting statistics. Thank you for joining us today. We hope you enjoyed our webinar on the new technology that's leading the way to lower dose myocardial perfusion imaging. Please don't forget to take your test, and remember you must score an 80% or above in order to receive your certificate.